Well, it's an interesting question, but the main difference is that in very young children, arrhythmias can disappear by themselves. So we know that in children under the age of a year, 80 or 90% will resolve by themselves. So it's unnecessary to treat them very aggressively. We usually maintain them on medication and would only consider ablation when they may be 3-4 years of age onwards, because so many of them resolve by themselves. And we find in our centre extremely low rates of needing to do a catheter ablation in a child under the age of a year. If we do it, it's because the child is particularly sick and medication's not working. But I have to say, in the last 15 years, I think I've had 2 children in that age group who've needed an ablation. So again, my training initially was in adult cardiology and adult electrophysiology. I then had pediatric cardiology training, so I have a foot in both camps, as it were. But I do know that my colleagues in pediatric electrophysiology find it very helpful to work with adult electrophysiologists. The main reason is that adult electrophysiologists tend to see many more cases on a regular basis, whereas pediatric electrophysiologists see fewer cases. On the other hand, pediatric electrophysiologists are much more suited to looking after the children in general. The child is cared for in a pediatric environment, pediatric nurses, pediatric anesthesiologists, pediatric intensive care unit. So both the pediatric electrophysiologist and adult electrophysiologist bring a lot to help the child. In big pediatric cardiology centres in general, however, all the work is done by a pediatric electrophysiologist. In smaller centres where the pediatric electrophysiologist doesn't see that many patients, he may need a greater deal of collaboration with an adult electrophysiologist. So implanting a pacemaker or defibrillator in children is different to adults. The main difference is that the child is growing. In an adult, if you put in a pacemaker lead, you don't expect the adult to grow, and therefore if you've put in a certain length of lead, it will be good for the rest of the patient's life. If, however, you put a lead in a small child, as the child grows, the lead does not grow, and therefore the lead starts to pull out the heart. We have developed certain tricks to allow us to put leads in small children which would continue through to adult life. And in fact, with the progress in lead technology and with better techniques, in fact, putting pacemaker leads into very small children is no longer such a problem. In fact, we put pacemaker leads even in children down to 3 kilos, 2.5 kilos without any problems. So patients with congenital heart disease develop new arrhythmias the longer they live because of the fibrosis and high pressures in the heart. Some of these patients are managed to be treated by catheter ablation, but in some, the scarring process and the size of the atrium makes ablation very difficult. In these patients, repeat cardiac surgery is able to deal with the arrhythmias as well as the hemodynamic problem at the same time. So while catheter ablation is very effective for pure arrhythmias, when you have patients who have both arrhythmic problems and hemodynamic problems, then cardiac surgery to tackle the arrhythmia and the hemodynamics is usually the best way forward. So I've been a pediatric electrophysiologist for 25 years now, and the most exciting thing that I've seen, other than the developments in pacemaker leads, has been the development of catheter ablation. And when I remember children many years ago used to be on 1, 2, 3 different medications for many, many years, coming into hospital with repeated attacks of tachycardia, these days you know they can be cured with a catheter ablation, and to me this has been the most exciting thing about pediatric electrophysiology. I suspect very much in the future our ability to ablate more effectively, more quickly, will develop further. Currently, we are able to do ablation virtually without using any X-rays at all, and this again is a really important step forward.